Hello and welcome to Best of the Day from the 2013 combined meeting of ECHO, ESMO, and ESTRO being held this year in Amsterdam in the Netherlands. I'm Dr. Jim Epstein, and this evening we're meeting with Dr. Fabrice André from the Institut Gustave Roussy in Paris to talk about some of the data at this year's meeting regarding breast cancer. So Fabrice, thanks so much for coming. Appreciate you taking time out of what I know is an extremely busy schedule.
Thank you for the invitation.
Well, there were a number of interesting topics I want to discuss with you this evening, and one has to do with some changes in radiation therapy and the management of early breast cancer. And then we want to get into some of the HER2 positive data, especially regarding some of the novel agents. And then we'll talk a little bit about biomarker studies related to ER-positive disease and the use of everolimus. So first, as far as radiation, there were a couple interesting abstracts that caught my eye. One had to do with a renewed interest in irradiation of the internal mammary chains and the medial supraclavicular chains, something that was pretty standard years ago, back in the 50s and 60s, and then fell out of favor. And now there's this very large trial with lots of long follow-up that suggests maybe we should reconsider this. And then there was another study looking at management of the axilla in patients who had positive sentinel nodes. Should you go on and dissect them, or should you avoid dissection and just do axillary radiation? So let's start with the old inverted L or hockey stick radiation. What is the story with this trial? This was like 4,000 patients who participated in this effort.
So first, this trial is a very large effort, mainly European effort from EORTC. So it's a trial that has included more than 4,000 women with early breast cancer, late 90s, early 2000. So the beauty of the trial is that it's a very large trial with a long follow-up. So this trial can evaluate the impact on overall survival.
A lot of statistical significance.
Yeah, and the question that is being addressed is whether the radiation therapy of internal mammary chain and supraclavicular node can improve the outcome. So the result is there is a 2% difference in overall survival in favor of radiation therapy. So that are the raw data. Now the question is, what are we going to do with that?
Right.
Are we going to apply this to all women? Are we going to select patients? So I think what we have here is a first signal from a very large study that doing this radiation therapy could improve the outcome. Then we need to see in better detail what are the groups of patients who got this benefit. Right. Because we need to keep in mind that adding radiation therapy to already existing therapeutic can also have some possible detrimental effects. So here we really need to know who are these 2% of patients who will have improved outcome with this radiation therapy. So we will see, but we can assume that patients with high level of lymph node involvement in the axillary could derive high benefit from this treatment. So I think this is really an important trial, long-term follow-up, large number of patients with an improvement in overall survival. Now the perspective are to which patient are we going to apply this advance?
So it seems like the pendulum has sort of swung back in the 50s and 60s, the more radical the local treatment, the radical mastectomies and extended radical mastectomies a la Halsted, and a lot of radiation therapy was a trend, and then it swung the other way, thinking that breast cancer is a systemic disease, minimize what you do locally, but worry about distant spread. Now it looks like it might be swinging back a little bit and more intensive local therapy.
Yeah, actually we get signal from the two sides, because some trials are also addressing decrease in the local regional treatment, like axillary node dissection and sentinel node biopsy. But some other trials are addressing the opposite, increase in the local management. I think all these questions, they all matter of, they all relate to what is the local regional extension of the disease. And indeed, patient with a small tumor burden, in this patient, we can decrease the local regional treatment. In some other patient with large tumor burden, then the other question is whether increasing the local regional treatment can improve the outcome. So I think what we are rediscovering here is just personalizing the local regional treatment according to the extension of the disease. So actually we are moving from one treatment for all patients to better consider the local regional extension to personalize the local regional therapy.
It concerns me that, say, a woman has a medial quadrant HER2 positive breast cancer with a few positive nodes. She's going to get AC and paclitaxel and trastuzumab, and then you're going to irradiate her breast, and then you're going to irradiate the internal mammary nodes and the supraclavicular nodes, and then who knows what you'll do about her axilla. She's going to get a lot of potentially cardiotoxic therapy. Does this worry you?
So that's a very important question, because one of the limitations of this trial is the fact that it has been done during a period when the systemic treatment were not the same.
Right.
So now, important question is how the new systemic treatment will integrate with these new advances in radiation therapy. We have some piece of data about this question. So some randomized trial testing trastuzumab suggests that there is no additional toxicity of doing trastuzumab with radiation therapy. We need to keep in mind that there are new technologies for radiation therapy that can spare the heart. So that is probably something that is going to be important in the near future. But here we have two questions. So first is, how do we integrate new systemic treatment with, I would say, old clinical trial for radiation therapy? And second question is going to be, if we are concerned about potential toxicity, here it's probably the positioning of new technologies for radiation therapy that could spare the heart.
It'll be interesting to see how the information from this trial is integrated into clinical management.
Yeah, but I think in this trial, because of this limitation, I think the investigator must absolutely define the benefit according to each molecular subtype. Because if they found important benefit in HER2 positive segment, then indeed the question with anthracycline and trastuzumab must be concerned and maybe can generate new trials that would really address the question of combining internal mammary chain plus trastuzumab and chemotherapy in kind of phase 2 safety trials.
Very good. Let's move on and talk a little bit about the axilla. There was a trial presented at the meeting this year randomizing patients who had positive sentinel nodes to either lymph node dissection of the lower two levels of the axilla versus axillary radiation and avoiding the axillary lymph node dissection. How did these two modalities compare? I would always worry about the incidence of lymphedema. Is it worse with the axillary dissection or worse with radiation and radiation fibrosis in the axilla? What did the investigators tell us?
So first we need to remind the design. So the question was radiation therapy versus axillary node dissection versus both in patients with positive sentinel lymph node. And the results suggest that radiation therapy could be less toxic, I would say, than axillary node dissection in terms of lymphedema. And the difference was highly significant. So the question now is, once again, how do we integrate this data in the context of, first, some trends in clinical research suggesting that we can decrease, in fact, the surgical management of the axilla. So soon the question will be radiation therapy versus nothing, or axillary dissection versus nothing. So we need to consider this question. The second question is also in terms of management. We need to keep in mind that performing axillary node dissection allows us to have the amount of lymph node involved. That could be a decision criteria for the adjuvant chemotherapy.
Prognostic information.
Yeah, so that is something that is important that we can miss with the radiation therapy. So for me, this trial is one indication. But once again, when we integrate this trial in the landscape, for me, I would not implement this trial tomorrow in my daily practice. I need more information about how can we derive some information about prognosis, and do we really need to make axillary node dissection in all patients with positive sentinel lymph node?
So if you have one sentinel node that's microscopically involved versus 3 sentinel nodes that are macroscopically involved, it's going to impact the decision.
Yeah.
Very good. So, we'll wait and see. So let's talk a little bit about HER2 positive disease. We've had trastuzumab available for a number of years. It's been an amazing agent for patients who are HER2 overexpressing, but now there's a new agent, pertuzumab, that's also FDA approved, and then the newer agent, TDM1, comes along with a linked cytotoxic agent. So the original data from the TDM1 trial, the Amelia trial, looked extremely strong and led to approval by the FDA in the US. But now there's been another trial, the Theresa trial, that was presented at this year's meeting. And there are other trials that are ongoing, the Marianne trial. So tell us a little bit about where things stand with TDM1, and how you are utilizing these 3 agents, and lapatinib as well, for that matter, in your breast cancer practice.
So, indeed, so that was very important presentation. Theresa Trial is the first report of a randomized trial. And the question was really about the medical usefulness of TDM1 in already pre-treated breast cancer patients. The research showed that there is improvement on PFS and improvement on overall survival. So we have several points to discuss. The first, the most important point, is the fact that this trial confirmed, in fact, the Emilia trial, who already showed that indeed TDM1 was improving outcome in patients already treated with trastuzumab. So in some way, it's the confirmation of Emilia with a different population, different comparator, but in terms of data, it's a for me, it's a confirmatory trial who show that we need to have access to TDM1 for our patient. So all these trials have been done in patients who were resistant to trastuzumab. And this is something that is very important because currently the positioning of the drug is resistance to trastuzumab. Then there is other trials who are testing TDM1 in the first-line setting and who will tell us whether TDM1 improved outcome as compared to Taxane plus trastuzumab and pertuzumab. And also, and this is something very important, whether TDM1 plus pertuzumab improved the outcome. So then we have the following landscape. So currently, the Theresa trial confirmed that we need to have TDM1 for patients pre-treated with trastuzumab. And the perspective is, should this drug become the standard first line in patients who were not treated with trastuzumab? And the next question is, should this drug be combined with pertuzumab? So that are three different points. What is the positioning? Is it effective first line? Should we combine with pertuzumab? And currently, I think, that we indeed need this drug in patients who are resistant to trastuzumab. And the first line, currently, I would say the gold standard is trastuzumab plus chemo plus pertuzumab, keeping in mind that this drug is not reimbursed in most of the countries.
So in the Marianne trial, they're comparing trastuzumab and a taxane with TDM1 and pertuzumab and TDM1 and a placebo. So that trial will give us a tremendous amount of information on the relative benefits of all, whether to use TDM1 up front or save it for a salvage agent.
Yeah, that's actually the next question after Theresa and Emilia. It's whether we should use TDM1 first line in patients who never received trastuzumab. So, and this will be answered by the Marianne trial, who is exploring also the combination, as you thought, between TDM1 and pertuzumab.
Very good.
And the next step is, of course, the adjuvant setting, trying to evaluate whether the use of TDM1 in the adjuvant setting could save toxicity while improving the outcome.
Very good. There's going to be a lot of really interesting data come to light in the next few years. So this is great. Well, the other agent that has shown activity in trastuzumab-resistant HER2-positive breast cancer is everolimus. And I know that you participated in the Valero 3 trial that Ruth O'Regan presented the data at ASCO. Remind us a little bit about that trial and what the data presented at this year's ESMO meeting, looking at some molecular biomarkers among the patient populations as to whether or not you can select out those patients who are most likely to benefit from everolimus.
Yeah, indeed. So Valero 3 trial is evaluating the efficacy of everolimus in patients who are resistant to trastuzumab. So everolimus is an mTOR inhibitor. mTOR is a protein activated by HER2 that generates protein synthesis. And some preclinical and phase 1 data have suggested that mTOR activation could be involved in the resistance to trastuzumab. So now this Valero 3 trial is evaluating whether the addition of everolimus to trastuzumab plus vinorelbine could improve the outcome. And the results showed that there is a statistically significant improvement in terms of PFS by local review when everolimus is added to this backbone treatment. The PFS moving from 5 to 7 months, and the hazard ratio was 0.77. Now the question, of course, so it's a significant benefit, but it's a small benefit. So the next question is whether we could have some biomarkers that could predict which patient derive high level of sensitivity. And in this trial, 3 different biomarkers have been evaluated. The first one is phospho-S6 kinase, that is the downstream protein of mTOR, so it's a surrogate of mTOR activation, so phospho-S6. PTEN loss, so PTEN loss being correlated with the activation of mTOR, and PS3 kinase mutation. And the results show that PS3 kinase mutation has no predictive value, and that low PTEN expression was associated with an increased sensitivity to everolimus.
And loss of PTEN has been noted to be a poor prognostic factor for some time.
Yeah, but the data are a little bit controversial. And that is always the problem with the biomarker studies, that sometimes we have very exciting news, and the study after does not validate the previous one. So here, so first, the phospho-S6 kinase was also predictive for high sensitivity. But of course, the question is, will this data be validated in other randomized trial? And here, we are thinking about Valero 1 trial. That was a trial testing everolimus in combination with trastuzumab and paclitaxel. So if the Bolero-1 trial validates these biomarker findings, I think that would be a very, very strong signal that we have identified a population that is sensitive. At the present time, it's just one hypothesis. I mean, these two biomarkers are just hypotheses for clinical or biomarker research.
Still a lot of work to be done.
Yes and no. What is being done is validation on a specific trial that is Bolero-1. So I would say more, we have to wait until Bolero-1 is finished. So not so many work, but more waiting time. Waiting
time, right. And then what about Valero-2? This was another everolimus trial, but in a different population, in a hormone receptor positive population, which combining everolimus with exemestane, and they have also gone back and done molecular analysis to try to select out patients. What do we know about that data?
So that are very important data. The preliminary data were presented at the ASCO. Now we have all this analysis of biomarker. So what has been done? The Bolero-2 compare exemestane versus exemestane plus everolimus, and in a subset of patients, they have run next generation sequencing on 180 genes, and they have found that amplification of FGFR1 could be associated with less sensitivity to everolimus, and that when a tumor is presenting high number of mutations, there is less sensitivity to everolimus. So that are these two data. Once again, these serve validation study, but if they are validated, they are very important for the following reason. First, FGFR1 amplification can be targeted because we have ongoing development of FGFR inhibitors. So one, we could consider development of combination between FGFR inhibitor and everolimus in patients with FGFR1 amplification. So that is the first perspective. The second question is about the patient who presents high level of mutation. If the validation studies show that patients with high level of mutation, high number of mutations are resistant to everolimus, then we could have a biomarker to select patients for everolimus. The question behind is whether the genomic instability could correlate with resistance to targeted therapy.
So the greater number of mutations that pile up can really interfere with response. That's interesting. I know that there's a lot of interest in FGFR overexpression in a lot of malignancies, and there's a trial in renal cell cancer that's going to be presented at this year's meeting also, looking at an FGFR inhibitor. So let's finish up with an update on the Azure trial, and this was a look at the value of zoledronic acid in the adjuvant setting. Remind us a little bit of how that trial was designed and what the investigators are presenting at this year's meeting.
So basically the question is the following one. It's whether adding zoledronic acid to the standard of care could improve the outcome of the patient. So here we are in the middle of a controversy because we had initial data with zoledronic acid from ABCSG suggesting that zoledronic acid could improve the outcome of patient. We had data from UK suggesting that zoledronic acid did not improve the outcome of early breast cancer patient. And we have preliminary results suggesting that zoledronic acid could improve the pathologic complete response rate in the neoadjuvant setting, and some preliminary analysis suggesting that it could improve the outcome. So here, this is a highly expected result because now we are going to have the analysis on overall survival to know whether or not in this additional trial, zoledronic acid is improving the outcome. So the presentation is tomorrow.
So we shall see.
I don't know the result.
So in this study, was this all comers with early breast cancer? Were they selected out as far as hormone receptor positive or triple negative or HER2 overexpression? or how is it designed?
This I don't remember. I think it's all colors.
So we'll have to wait and see.
Yeah.
All right. Well, it's been whether or not zoledronic acid has actual anti-tumor effects other than just its bone effects is a controversial area in a number of malignancies.
Yeah.
Prostate, myeloma, and breast cancer. So we'll hear more tomorrow. Well,
we will see.
Fabrice, thank you so much.
Thank
we don't
you.
want to keep you any longer. I know you have other events going on this evening, but we really appreciate your stopping by and sharing your thoughts and perspectives with us.
Thank you.
You bet. And thanks to all of you for watching this segment of Best of the Day from the 2013 Combined Echo-ESMO-ESTRO meeting in Amsterdam. We hope you will watch other segments from this year's meeting. Thanks again.